That is, how do you clinically evaluate the cuboid for a shift or displacement? What tests can give you the information you need to create your treatment plan? This is really important to be clear about because it'll play a major role in making a diagnosis and then determining the next action step or steps that you need to make. Well, first of all, you need to ask your patients quality questions and listen carefully. One of the first questions I ask is, where does it hurt? I know, you're thinking, that's a quality question? Well, it is when you listen to the reply, because what your patient will say is usually something along the lines of, well, it kind of hurts around here, and they tend to be rather non-specific about the actual site. They generally run their hand or their finger right along the whole lateral border of the foot. Now, this is really important to notice because remember how I listed off all the articulations of the cuboid in the last video? We've got the calcaneus, we've got the navicular, lateral cuneiform, fourth and fifth metatarsals, let alone the number of ligaments, tendons, connective tissues that are all associated with the cuboid. And then it's not uncommon to have patients describe radiating pains and symptoms around the ankle and even up the leg, which is where the peroneal tendons and muscles run. You'd also need to investigate the relevant acute and chronic history of accidents, injuries, surgeries, their activities, both recreational and occupational, plus other treatments that they may have already tried. Now, you know the drill. From a physical exam perspective, I'll investigate their body posture, I'll look at their foot posture, I check their gait patterns, but what I want to go through with you today is what tests do I do specifically on the cuboid. And I'll generally do this with the patient seated in a supine position. And if you can do it with the patient prone, I reckon it's easier to do them with them supine. Now, your hands and your sense of touch are really important here. Your surface anatomy, it better be switched on. The cuboid's landmarks can be a bit tricky, so let me share the most common rookie mistakes that I see when teaching students how to find and evaluate the cuboid. First, let's identify the two primary landmark reference points. One is the styloid process, and fortunately this is fairly obvious to us. Once we've identified the styloid process, the next step is to be just proximal and behind it, and you move your thumb and forefinger medially towards the midline of the foot until you get to the fourth ray. And then you stop. Now look, right here, what can you see? It's between my thumb and finger, I've got the cuboid. And what could be simpler? Well, let me tell you what the rookie mistakes are, and you can write these down so that you don't waste your time doing them. 1, students can be too distal. They don't go proximal enough. And often they'll go from the medial process, the styloid process, to the base of the fourth and fifth metatarsals. That just ain't right. 2, students can be too lateral. They don't go medial enough. You see, you've got the medial border of the cuboid, you have to practically be right into the middle of the foot. It's deceptive how far medial you have to go. So the 2 keys you must remember for correct contact points are go more proximal and go more medial than you think. Okay, once you've got the correct contact points, the next thing you need to do is move the cuboid through its natural range of movement. Now, the cuboid will generally glide superiorly and inferiorly in the frontal plane with a bit of inversion and eversion. So it goes like this, up and in, down and out. That's up and in and down and out. In a typical adult with a healthy range of motion, this movement will be in the order of 3 to 5 millimeters. So it should be both palpable and even visible. A displaced cuboid is usually stuck or limited in its full range of movement. And the classical sign is exquisite tenderness on the plantar aspect of the medial part of the cuboid right here. I'm breaking out into a sweat just thinking about this because my own right cuboid can get stuck in this position, and whenever it's worked on, well, that's a special experience. But why the specific medial point of tenderness? Well, think about it. We discussed the medial displacement of the cuboid in the eversion direction. So what's going to happen to the transverse ligaments attached to the cuboid and the cuneiforms? Stretched, strained, trigger points? Oh yeah, very special. So if you're palpating this area and your patient flinches, it'll confirm that you're on the correct side. So then you just push harder. Now, I'm not being a masochist. You're actually treating the trigger point. So press harder and charge more for the trigger point therapy. I told you I wanted you to benefit commercially, so there, you have it. An extra income source for you right there. Look, now that the tenderness confirms that everted displacement of the cuboid, that's a good thing to know, isn't it? So now, what are we going to do about it? Well, that brings me to step 3 of the 4 steps of cuboid mastery, and that is exhibit. Meaning I'm going to put on an exhibition of 2 treatment techniques for helping an everted cuboid. Ready? Okay, the first treatment technique is an exercise which relates to the plantar tissue restrictions through the sole of the foot. Now you need some high-tech equipment for this one. Here's mine. So this piece of wood is called a dowel in English. In French, they call it a stick. And in German, it's called Stick. Hey, who says Australians aren't multilingual? We use 19mm dowel in diameter. We used to use 22mm, but that was just a bit too aggressive. Okay, now I'm going to edit in how this exercise works for you right now. I'll see you on the other side in about 30 seconds. Place the timber on the floor and begin by resting the balls of your feet on it. Now slowly creep over the timber, making sure that the timber stays still. Your aim is to have your feet slide over the timber, creating a deep tissue massage effect. For some of you, you'll come across points that are exquisitely tender. These are typically trigger points in the muscle, and they need to be released. If you find such a point, stay resting on that point for 5 seconds. You'll notice that the tenderness eases off slightly, and then you can progress forward to find the next tender spot. Once you get to the end of your heel, you can say, "Phew, only 2 more times to go." So the great benefit of this exercise is that it releases a lot of the plantar tissues that get caught up in the cuboid-related problems. When these tissues are released, it prepares the way for the next exercise, which is more specific for the cuboid that gets displaced in an everted direction. This next exercise is a self-mobilization exercise that your patients can do for themselves at home as well. This is great for speeding up their progress because they can work on it every day. You're going to have a ball with this exercise, let me tell you. In fact, you're going to need a golf ball. See? I said you were going to have a ball. Okay, enough dad jokes for now. Now, remember the cuboid displacement, or the typical displacement of the cuboid gets displaced in an everted direction. Well, we're going to now use the golf ball and gravity to mobilize the cuboid back into position by applying an inversion force to it. Cuboid has everted, we're going to invert it back. Make sense? Great. So the most important tips to know to make this self-mobilizing exercise work are as follows. 1, the correct position of the golf ball. 2, the correct force or the application of force. And 3, how long to do the exercise for. So let me give you those directions clearly so that you and your patient don't make any of the common rookie mistakes. So first, the position of the ball is it needs to sit directly under the medial aspect of the cuboid right here. The most common rookie mistake is placing the ball either too distally up on the metatarsal basis or laterally on the cuboid, exacerbating the everted direction of the cuboid. Now, to find the correct position, there's a great landmark, and that is the tender point or trigger point that forms in the transverse ligament or capsules right here. When your patient finds the correct point, it is exquisitely tender. So get them to roll around a bit and find that point precisely. Once found, stop. And it's at that point you're going to apply a specific direct force. So it's not going to be a rolling massaging force, rather it'll be a direct application of force vertically to invert the cuboid. And that's the second point for this exercise, or the second rookie mistake, is that they tend to roll around and massage the area. So you have your patient seated, not standing, that would just be way too much force. Save that for your worst enemy. While seated, get them to keep the toes on the floor and roll the heel around and find that special exquisite point. Once found, the patient rests their hands on their knee to control the amount of force that they use to push down on the golf ball, on the cuboid. They'll push and hold as hard as they can tolerate, say about 7 out of 10 on a pain scale, so that it's uncomfortable but bearable. Now, the third point to get the best physiological effect from this exercise is the duration, or how long to do the exercise for. The pressure is maintained for 8 seconds. Then they release the pressure for 5 seconds. Then apply the pressure again for another 8 seconds, and then release for 5 seconds. And then it's a third repetition of 8 seconds and release. So that's 3 repetitions of 8 seconds of pressure. Now, the reason for the 8 seconds is that the research shows that the 8 seconds is the optimum time to release the collagen cross-linkages that form and hold the cuboid in a stuck position. Okay, then repeating that whole routine twice daily is practical and beneficial for the patient. And normally you would do this for 2 weeks at that intensity. Depending on the amount of improvement your patient experiences, you can reduce the frequency once you get more than 50% improvement. So if after 2 weeks your patient is 50% improved or better, reduce the exercise to just once per day for the next 2 weeks. I typically prescribe the exercise then once on alternate days for the next 2 weeks. So it's a total of 6 weeks of mobilization therapy on those collagenous tissues, which is the optimum time frame for the best long-term results. Now, meanwhile, the dowel is actually continued through this whole 6-week time frame too. So, of the cuboid in the last video, we've got the calcaneus, we've got the navicular, lateral cuneiform, 4th and 5th metatarsals, let alone the number of ligaments, tendons, connective tissues that are all associated with the cuboid. And then how do you clinically evaluate the cuboid for a shift or displacement? What tests can give you the information you need to create your treatment plan? This is really important to be clear about because it'll play a major role in making a diagnosis and then determining the next action step or steps that you need to make. Well, first of all, you need to ask your patients quality questions and listen carefully. Hurts around here, and they tend to be rather non-specific about the actual site. They generally run their hand or their finger right along the whole lateral border of the foot. Now, this is really important to notice because remember how I listed off all the articulation? One of the first questions I ask is, where does it hurt? I know, you're thinking, that's a quality question? Well, it is when you listen to the reply, because what your patient will say is usually something along the lines of, well, it kind of